Hello and welcome to the next episode of the Psychedelic Medicine Podcast. I'm Dr. Lynn Marie Morsky, your guide on this journey, and today we're going to be discussing ketamine-assisted psychotherapy for anxiety with Dr. Thomas Kim. Dr. Kim is the Chief Medical Officer of Noma Therapy, a ketamine-assisted psychotherapy program available via telehealth and in person with licensed therapists. Now, before we get to Dr. Kim, just a reminder that the Psychedelic Medicine Podcast is for educational and informational purposes only. Nothing here is to be construed as medical or legal advice. And a reminder, as always, if you are a clinician and you would like to learn more about psychedelics and how they may benefit your patients, please check out the Psychedelic Medicine Association. It is our mission to get you up to speed on psychedelics so you can feel comfortable when patients come in with their psychedelic related questions, asking about microdosing, all of those things, so that you feel fine to have those conversations. It's not a deer in the headlights moment like I'm sure I remember back in residency when somebody would come in asking me something I had not heard about at all. We want to prevent that. We want you to feel confident and comfortable when patients come in with their questions. So please check out the Psychedelic Medicine Association at psychedelicmedicineassociation.org. Now, without further ado, thank you so much for joining us today, Dr. Kim.
It's a pleasure to be with you.
I am really excited to have this conversation because as Dr. Kim knows, and as many people who may be dealing with anxiety know, there are so few good treatments for anxiety, despite the fact that it is one of the most common things that people struggle with in mental health. So, Dr. Kim, I'm so excited that we're having this conversation. If we could start off by talking a little bit about your path to becoming the chief medical officer at Noma, because I know that's going to lead us into how you become passionate about working with some of these therapies.
Absolutely. I have had a bit of an unusual professional path, which is to say, none of it was planned, and I kind of made it up as I went along. But I started training as an internist and a psychiatrist with it, which is masochistic in its own right, to do 2 residencies. But what it did was it allowed me to appreciate the divide, the crack in between specialties, where I see a lot of the challenges we face in care delivery today as sort of stemming from the fact that most folks sort of stick to their yard and there has to be a better way. It was in my fellowship that I discovered telehealth, largely for beer and pizza money, but almost immediately I was like, why can't we do this everywhere? And that sort of put me on a path towards trying to figure it out. And I've been incredibly gratified at just the serendipity of being able to create models of care to support patients who just historically had no options. And I've cared for the incarcerated, military folks, disaster victims, people living with HIV and AIDS, the geriatric, you name the vulnerable population, I've had the good fortune of supporting them. And not too long ago, I was approached to join the founding team at a startup, and they asked me a fairly simple question. How would you do ketamine-assisted psychotherapy? And so I do what I always do when in my approach towards something that's sort of complex and unknown. And if I had to sort of invoke my general perspective on it, one of my favorite quotes is from Oliver Wendell Holmes Sr., the physician, not the jurist, who talked of simplicity on the other side of complexity. That's something that I strive for. Holmes would have given his life for it. I'm not sure that I would I would do the same. But when I looked at the landscape of ketamine and psychedelics broadly, what we see is a very, very nascent field with no universally agreed regulations, guidance. There's certainly no textbook or definitive evidence to tell us, to guide us on how to do this. And wouldn't you know it, I've been here before. After 20 years of working in exactly that same context in telehealth, I sort of embraced the opportunity to look at ketamine and try to figure out, like, how are we supposed to work with this particular medication and agent? And in the absence of rules, my default position is always to adopt the higher bar of values. And my values really stem from the idea that I like taking care of people who really need the help. And it's not about right and wrong or this or that. It's really more nuanced. And, we tend to often talk about, well, is ketamine clinically effective? Well, in my head, I start asking questions around access, cost, the formulation, how that impacts tolerance and safety, and what are the general clinical indications that help guide us, in the use of ketamine, a very old medicine that has just, that we've only recently discovered a very new application for.
Yeah. Well, I love the fact that you were around in the very old school days of telehealth. I was one of the first docs on Teledoc where you did it via the phone. I'm assuming that's how you did it, right? This is be
Oh, no, no.
so,
I,
oh, how
I
did you do
was
yours?
using the fancy rigs from Polycom and Tandberg, connected to T1, T3
Mm.
lines at an incredibly high cost. And the fact that over time, continued effort in the field has led to cost-effective, scalable solutions that can reach more people. I'm really hopeful that we can find solutions in the psychedelic and ketamine landscape to do a similar thing.
Yeah, absolutely. And I think you put a point on something that's important here is we have this balance between what is the absolute most effective and safest way to do something versus what is going to bring it to the most amount of people, make it the most accessible at a price point they can afford. And that's a really delicate balance, especially in ketamine. And I know that's going to come up. So I'm excited for this conversation. So let's get into anxiety. How have you, what have you seen in the research and your thoughts on what has come up about ketamine for anxiety?
So, diagnostically, for those of you who weren't keeping track, um, our profession has a tendency to sort of revamp the lenses through which we look at mental distress, and it's broadly described as the DSM or the Diagnostic Statistical Manual. Version 5 came out 2013. And as I understand it, version 6 is inbound in the next five, probably 10 or 15 years. And the key features of the DSM-5 was a sort of a rearrangement, a reorganization of certain mental illnesses. Specifically, they kind of stripped out PTSD, OCD, panic, agoraphobia as their own separate entities where historically they were sort of under the umbrella of anxiety. And I think that that speaks to the importance and the magnitude of anxiety as a diagnosis. It impacts one in five adults in the last year, roughly, based on epidemiologic studies. If you're looking at all time at any point experiencing anxiety, that number turns to one in three. So this is quite common. And as I came up through my professional career, an interesting thing started to happen. I started as being an excellent diagnostician. I could tell you exactly what was wrong with you after having a clinical interview. And very quickly, the notion of diagnoses as being unhelpful began to sort of well up in my head. And ultimately, I wound up sort of with an unusual pattern where I would tell patients blankly, I could care less what your diagnosis is. We're going to focus on function. But how I understand anxiety is that it's a complex constellation of symptoms that has considerable overlap with depression and trauma. Interestingly, while anxiety and depression tend to track together fairly commonly, the order of like 60% comorbidities, depending on what research you look at, PTSD likewise tracks both depression and anxiety. So I'm not sure we're actually talking about different entities, but sort of the same entity that manifests differently depending on who you are as a person. And then that becomes helpful on the applicability of ketamine, which for the first time in decades is a very, very promising non-serotonergic intervention that has very promising data to suggest that this could perhaps help, maybe even help better for reasons that I'm happy to go into when we talk about ketamine. But anxiety is a weird thing. I see it all the time. I frame it in a very different way that tries to not label somebody as broken or less than, but instead largely having a very understandable response to what is most likely some either trauma, adverse childhood experience, or a non-medical driver of health, otherwise known as social determinant of health.
Gotcha. And so that being said, where you anxiety is one thing. Like if you were to go to PubMed and look at for research and just put in anxiety, that's one thing. I think the point you are making is that it's generally the feeling of worry or fear that comes along with anxiety is part of so many other things that it's hard to tell. It would be kind of reductive to look at solely ketamine for anxiety if we were looking at the research. It's more helpful to extend to the different things that we've seen ketamine be studied for, including things like depression and PTSD.
One comment I can have specifically around anxiety is that in my clinical experience, what often happens is a patient waits until their distress has risen to such great levels and they're reporting primarily depression. And they've made the difficult and brave decision to ask for help, perhaps the most brave thing anyone can do. And then as they go through care, there's a moment where they'll report back to me and say, "Oh my God, Dr. Kim, I'm so much worse." And they'll begin to describe these anxiety symptoms that are being unmasked now that their depression has been relieved a little bit. And so again, it's really important, if there were any message from this episode, is for patients to not look at, well, first, not to look at a diagnosis as some label that you're broken. It is simply overlapping constellations of symptoms that might be assisted with ketamine-assisted psychotherapy.
And can you just briefly discuss, before we get into your how you practice with patients and the kinds of things that you've seen, what the research that has come out has tended to show in relation to ketamine's efficacy for that constellation of symptoms?
I did just that. And in preparation for this episode, I did a deep dive, such as it is, for ketamine and anxiety specifically. And through basic PubMed Boolean search, it spat out 1,375 citations, which is not a lot, in fact. And of those, most of the citations were roughly in the last year. And so if I had to digest the data, broadly, we're still early in the process, meaning almost every single paper says more research needs to be done. There's incredibly promising data to suggest that this intervention has a positive psychological benefit on anxiety and more. But the key part is to recognize that this evidence, as such as it is, remains kind of variable. And so if I had to sort of give you a snapshot of the last 10 years of effort, one of the things that I noticed is that maybe 10, 15 years ago, there were a number of animal models looking at what ketamine does in this. So again, historically, ketamine is a dissociative anesthetic. Specifically, what is it? It's a non-competitive NMDA receptor antagonist, which every year I get further away from my pharmacology course. That means less and less to me. And which is why I frame it as a genuine non-serotonergic option for treating mental distress. And these sort of early papers that were largely mouse, zebrafish, rat models, looking at what ketamine does sort of in the very sort of micro scale, there was some of the conclusions that dropped out was that it's safe. There appears to be a positive impact on anxiety. And as you sort of roll forward, we then start seeing uncontrolled open label studies that confirms that it's largely safe, well tolerated, and effective in treating specifically treatment-resistant anxiety and or social anxiety, as well as all of the other things around depression. There's some alcohol data and other things. Even more recently, some of the things that I think are that sort of bear mentioning is periodically, either in the animal studies or in the clinical trials, there is an emphasis on the lack of long-term data. And I think that this speaks to safety. However, we might give ketamine for however long and in whatever quantity, I think it's really important that we be measured in the models that we develop and how we're sort of framing the use of ketamine. Again, me, from my weird perspective, a thing that I say routinely to patients is there is no cure in the bottom of the pill bottle, ketamine included. They are all incredibly useful, and when used effectively, can provide you meaningful relief from your psychological distress. But make no mistake, there is not a cure, which is why I'm such a huge advocate of therapy, and which is why ketamine-assisted psychotherapy also needs to be distinguished from ketamine therapy, which has its benefits, and there is evidence published that suggests it. But in terms of where do we go from here, I am full on in the camp of, if you're not pairing it with proper psychotherapy, I think we're missing an opportunity.
I'm very glad that you brought that up. I would love if you could discuss your thoughts on how the time wise that therapy should look? I know that if you're doing a higher dose ketamine session, doing therapy during it is useless. You're kind of out, you're not in a place you could be having that conversation. So generally, if you're going to have the therapy during ketamine, it would be a lower dose. Do you think that in your, prediction, again, this is something like you said that has not been, we have no head-to-head studies, I think, to this point
Not
on
that I found.
right on whether ketamine by itself versus ketamine with therapy in the session versus ketamine with therapy just surrounding the session, which is the best. But in your estimation, uh, is it enough to have the therapy, let's say within 48 hours while we know that critical learning period is still open? Or is it enough to just be having a weekly ongoing relationship with a therapist that you see, maybe a therapist you had even before you started the ketamine therapy, but now you've added ketamine to it? Does that still count as ketamine assisted psychotherapy? I'd love to hear your thoughts.
So I guess I would begin by saying my goal is not to find right and wrong in this very, very good question. I'm seeking that simplicity on the other side of complexity, that nuance. And I guess I'll start with how I talk about ketamine with patients and who come to me with obvious distress and high interest in it. And the way that I describe ketamine, other than saying it's non-serotonergic, is that the cool thing about it is that it's incredibly timely. The antidepressant anti-suicidal response is almost immediate versus a conventional med, which can also be helpful, but can take weeks, months, sometimes years to find the right cocktail that are complicated by lots of non-healthcare related complexities that impact a person's experience with conventional meds. So that timeliness is amazing, but it's also time limited. This no cure in the bottom of the pill bottle thing. And depending on where you look, you have to understand ketamine. There are two phases. There's the dosing experience, and then there's the response. A lot of folks place their emphasis on the experience of ketamine, and this gets into the sort of the discourse around the role of dissociation in terms of how it relates to psychological benefit. And then there's the response. And as you rightly point out, in my experience, 1 to 3 days following a dosing is sort of that primed opportunity where when you engage with a therapist, they're able to take advantage of what's broadly described as neuroplasticity. When I toss that word, you tend to see people like sort of glaze over. They have no idea what that means. And so the best that I can do in translating that $10 word is when you look at some of the functional MRI studies in people struggling with depression, anxiety, and trauma, there are notable areas of the brain that go dark, meaning the metabolism goes down. I don't think that it's off per se. Like, I don't like to think about that. What I think of it is you're looking at a stressed out brain swimming in cortisol, and certain parts just get overwhelmed by the noise that there's no meaningful signal. One of those dark areas happens to be where your amygdala is, what I broadly describe as the emotional seat of the self. And when you give somebody ketamine, new neural activity happens, including through the amygdala. So this is an overly simplified way. But when I share that with patients, saying now you're recruiting parts of your brain that had long been dormant, and this is how I explain this rather robust experience that you're having following a dosing of ketamine. I place the emphasis on the response. I'm less interested in your experience other than, is it well tolerated? Is it safe? And can you manage it? And thankfully, when I built the model a year and change ago for NOMA, there was even less evidence supporting the question that I had, which was, is dissociation required? And the answer is starting to come more into focus. In July of this year, a group I'm trying to remember the name of the journal. I want to say it was the Journal of Affective Disorders. And the team looked at essentially microdosing, standard psycholytic dosing, and high psychedelic dosing. And I think their formulation was IV, if I recall. The takeaway was there doesn't seem to be any meaningful needle movement with microdosing. I don't think that that's a definitive no, but they could not find measurable psychological benefit following microdosing. Standard and high dosing absolutely have a demonstrable psychological benefit. Interestingly, they could not find additional psychological benefit with high dosing. So the curious thing here is that there's not a right and wrong. You can get a benefit from high and standard dosing. So this is how we learn. And I'm keen to see how this goes. What I can say at NOMA is that we've adopted a standard psycholytic dosing approach, and we've paired it with proper psychotherapy, and we've constructed a discrete duration, meaning this is, I don't think people should be on ketamine forever. When you look at the literature and they talk about how it's likely a neurotoxin that impacts memory and a couple of other things when given, in repeated succession, there is no, I don't want to be alarmist. I'm not saying that ketamine is bad for you or it's going to hurt you. We just simply don't know. And if we're going to find out, I would rather take that measured psycholytic approach. And so far, we recently graduated our 100th patient, which was cause for lots of celebration. And our program runs roughly 4 months. And at the end of 4 months, those 100 graduates demonstrated something like 85% reduction in depression, 72% reduction in anxiety, which matches up with a lot of the literature. But their timescales are measured in weeks rather than months, which, to my mind, although this does not have the level of scientific rigor where I can say it with confidence, it's very suggestive that the way that we structure our program not only is effective, but it's effective longer. And I couldn't be more proud of that.
Oh, I love to hear it. Yes. So I think we've probably said this many, many times, but whether or not we know head to head that therapy is a beneficial add-on, we always advocate therapy basically for everybody, right? Like, I mean, at this
Everybody
point,
would benefit from therapy.
right? I mean, it's absolutely not that you need to have well, the same thing as going to a gym with or without a personal trainer. Who wouldn't, benefit from having somebody help you with your physical health? Nobody, there's no stigma there. How about have somebody to help you with your mental health as well, keep you on track, even if you're having a good week? I mean, there's weeks with my therapist, I've just shared the good things, and she's like, I'm glad that we stopped and took that time for you to like ingrain in your brain like what success feels like for this week, So just our
Absolutely.
weekly commercial, our biweekly commercial for that therapy is advantageous for all. In your practice, by the way, congratulations on those successful numbers. I love to hear it. In the patients that you see who are coming to you with more of that anxiety related constellation of symptoms, how do you talk to them, and how have you seen those symptoms? I know you said that statistic you just told us about their improvement in anxiety, but what has that looked like kind of on the front lines for you?
Um, I specifically prepared some anecdotes, and I'm already getting a little verklempt because
Oh,
I got permission from one of my patients. Um, this is a gentleman who was a Columbine survivor. And as you can imagine, he was wrestling with all three, the big three: anxiety, depression, and PTSD. And this is for 25 years. He ran through our program and he tipped into what we call maintenance, which is a reduction from biweekly to monthly dosing with a continuation of therapy because he was making good progress. And he came into session one day and he shared the following thing that happened to him. He had gone out to dinner with his parents. His father was described as one of those sort of stoic man of few words types. And as the son of an immigrant, I know exactly what he was talking about. And after they parted for dinner, apparently mom and dad get in the car. Dad turns to mom and says, "It's been 25 years and I think I have my son back." And mom starts getting all emotional and crying. She tells him the next day, he gets emotional. He tells me, we're all getting emotional. And it's really hard not to view ketamine as the catalyst of this moment, as something magical. Like, it really was extraordinary. Two decades of working in a conventional setting, I've never had moments like this where patients come on camera in tears, something that's commonly seen. And when I ask what's wrong, they would say things like, "Is this what hope feels like?" And while I can't guarantee this kind of moment for every single patient that comes through because everybody's unique, it's happening with such regularity since we started seeing folks a year ago, that it's enormously rewarding professionally.
I love that. Thank you for sharing, and thanks to your patient for allowing you to share that. What, in your experience as a psychiatrist, what are some of the, I don't know, ways that anxiety manifests, or what do you think leads to it? And how do you think ketamine may be so specifically a good catalyst for the kind of changes that can bring down those anxious feelings?
Well, I want to be clear to say that I'm far from the definitive source when it comes to mechanisms and the rigorous science that needs to happen around this stuff. But I think most people can appreciate the constellation of anxiety and what I'm going to describe as unhelpful worry. One of the ways that I begin to work with patients and their anxiety is that I introduce kind of an interesting definition. Some would define anxiety as being trapped in the future. Those same people would probably define depression as being trapped in the past, meaning our care goal should be how can we be more present in this stuff? The way people experience of it is, and you see representation of this, in media and a variety of other things, that knot in your stomach, the sweatiness, the palpitations, effectively what's happening is you're ramping up your autonomic fight or flight response. And this can be something that's triggered, which is more typical of a PTSD kind of picture that can escalate all the way towards, full blown, dissociation or ruminations and a variety of other things. But for folks who struggle with anxiety, it's simply feeling not comfortable with being in your own skin. And it paralyzes you. It prevents you from engaging in life. And because we're social animals, that's a terrible thing. It's simply it's a different facet of what I believe to be a shared entity with depression and trauma, and it's just how we experience it. Why do some people experience anxiety versus depression? Kind of difficult to say. But what I tend to do is I tend to look for their story. I mentioned to you the two sort of framings that came out long after I finished the 26th grade. That is adverse childhood experiences and social determinants of health. Why I find these framings to be so powerful is what we know about adverse childhood experiences is that when your brain has not been fully baked and bad things happen to you, children have a rough go of it. But what we now know is that that wound can extend far into adulthood and negatively impact both your mental and your physical health. Meaning pediatricians are now more alert to looking for ACEs and trying to mitigate those long-term risks by addressing whatever those might be. Turns out ACEs is just a subset of social determinants of health. And it really revolves around security. If you don't feel secure in your life, whether it's food secure, home secure, socially secure, it can lead to distress. And then how you express it, one of the more common types, obviously, is through anxiety. Unfortunately, females tend to carry the most of the heavy water around that. I think it's something like 40% versus 26% in incidences in terms of the preponderance of that. Adolescence as a subgroup, you see it through all phases. Unlike in depression, where it's largely once you get higher into the teens, like 16, 17, 18, where depression is more prevalent than earlier. How we go about understanding this remains an open question. And I do like the idea of identifying things that have happened in your life's journey that effectively lead to a very understandable response, manifested as anxiety or depression and trauma, rather than there's a biochemical thing wrong with you, you are less than, here, let me slap this label on you, let me throw 6 pills at you, see you in 3 months. Like there are different ways that we can approach the care of people struggling with this kind of mental distress.
I really appreciated your situation of anxiety as that trapped in the future, because I think what ketamine is so good at, along with a lot of other psychedelics, is bringing you into the moment. And it can and tell me if your patients have experienced something similar, but when all of a sudden their sights are brighter and the smells are more pronounced, that helps you be in the moment, right? If I'm in a moment and I'm not hearing or seeing anything, well, where am I going to go into my head in the future, right? Like that, why not? But I think that that's part of what these psychedelic therapies do, is help make the moment more vivid for you to have an easier time staying and experiencing it.
I think that's exactly right. And it's why I use that definition, because it's kind of helpful. It provides a sort of a toehold for patients to begin to appreciate who they are as something other than broken or less than. And you remind me actually of, I recently attended the American Society of Ketamine Practitioners here in Austin. And it was a wonderful event. Uh, uh, Part of our community, a community that I'm certainly, as the new kid, I'm really excited to be in. And there was one particular presentation where the presenter, I believe, was from Wisconsin and described ketamine not as a dose-dependent dissociative anesthetic, meaning at some level, all of a sudden dissociation happens. She instead looked at it as a spectrum of dissociation. And down in the psycholytic range, what we dissociate from are perhaps our unhelpful internal narratives, and some of the what ifs and the thoughts and the worries and the fears that distract us from realizing how good things smell, look, and are right here in the present moment.
Oh, I like that very much. And by the way, for everybody else out there, I'm always going to be like your glossary of terms. Psycholytic is, if you haven't heard us discuss this in the other episodes, a lower dose than psychedelic. So psycholytic is when we talk about kind of medium dose versus psychedelic is like the high dose where the person is dissociated and that kind of thing. So just as an asterisk to bring people back to what that means. But I love that description. You're dissociating from your everyday worries, that makes so much sense because you don't need to dissociate from your whole identity to start getting benefits. That makes total sense why the
Correct.
dissociation itself doesn't necessarily move the needle.
And there's not a bright line between psycholytic and psychedelic dosing. That's the other nuance, the art of our science. And for practitioners, I strongly encourage you to um, look for the line in your patient. And my general sort of prescribing philosophy that I was taught, I trained at Tulane University. And one of the things I'm so grateful for was we trained at an underfunded public facility, otherwise known as Charity, or the Medical Center of Louisiana in New Orleans, which is now no more following Katrina and Rita. But when you work in a resource poor, high need system, you kind of try and figure it out. And what it did as a prescriber was it taught me to always look for something that was affordable and always try to create a med plan that's the least amount of medicine for the most amount of benefit. And that served me well, whether or not you're resource limited or super in need. And it's how I approach ketamine. The least amount of ketamine for the most amount of benefit.
I love that. And I think if we have listeners out there who happen to be undergoing ketamine therapy or seeking ketamine therapy in the future, that this is a great point to remember is that increasing the dose to chase a certain feeling is
The
not necessarily the
experience. Yep.
safest. Yeah, the safest way to go. First off, this is not a medicine without side effects. Like whether or not it's neurotoxic, like you said, we know that there are bladder side effects. And so great point to remind people that staying on the lowest effective dose, as they call it, the minimum effective dose, that works for you is the best way to, I would say, not only try to avoid those side effects or minimize those side effects, but also minimize the real potential for addiction that comes with this. So if you could discuss that for a minute, if you don't mind.
So one of the many reasons that I approached this was my personal experience of trying to be the best prescribing hand in that least amount of medicine. But we're really coming back full circle to the lens through which I look at patients, which is I don't do anything to or for people. I know two or three things. I am good at walking along the path for however long. And for 2 decades, I was just your doc and I did the best that I could. The opportunity that I got with Noma was to create an intentionally time-limited plan, which places the emphasis on the fact that one day you're going to drive your own bus and you're not going to need me. It's a terrible business model. In fact, it's a wonderful business model because it gives us an opportunity to take care of more people because we set the intention of ketamine's not forever. You're not broken, you're struggling, and we're going to get you to a place where you may not need us. Now, because we're so new at Noma, there was every possibility that periodically, as somebody slides back into the hole of anxiety or something else, that they may need to re-engage. And you see a lot of providers out there today who talk about boosters, who talk about sort of re-engaging. I can't speak to exactly what's right, which is why I'm not interested in a right-wrong discussion. What I do know is that we are demonstrating lasting benefit, on the order of months. I'm curious to see whether we can extend that into years with continued effort.
Yeah, absolutely. And I think that's another great place where the therapy comes in, right? Like if you've done the initial work, had that neuroplasticity, started the work then. I mean, so often people have, even without a full dissociation, lots of people have realizations, and that's a great thing you can take to your therapist. Maybe without that acute ketamine journey, you would have not had such a realization. Great. Now you and your therapist have something you can work on. What if you unlocked one of the limiting beliefs that now for the next 20 years is something you and your therapist can work on? And like you said, you don't need the ketamine to have that realization every time. It did its job.
I uh, I couldn't have said it better. In our limited experience, because we're still new in the world, um, what we found, we have an internal model where we have our prescribers, we have our therapists and our guides as a care team that takes care of folks, and we're able to demonstrate these sorts of early results. Not soon after we opened, an interesting thing happened to us. Patients started coming to us and saying, I already have a therapist. And as the therapy advocate that I am, is saying, I'm not going to step inside that. Those are hard to make and they need to be nurtured. And so we quickly adapted into what we call our collaborative CAP option, where we are more than willing and interested in working with community therapists. And as we've been doing this, it's been wonderful. I've had therapists reach back out to me saying, I've been working with this client for 2 years, and what the heck? These last 2 months is a different guy. Like fundamentally, one of the things that gets me so happy and excited about our collaborative option is we're seeing, a broader impact. We're making more ripples, but more importantly, I think we're restoring the joy in the work that we do. And burnout is such a complicated, troubling phenomenon in healthcare and every other industry. And I mean, it's because we participate in a horribly broken system. Hopefully, we can do better, but being able to restore that professional satisfaction of feeling like we're of service and helping people is just wonderful. And so that's just an unanticipated side benefit of working in this space, that you get that sort of like, shot in the feels, as the kids say.
I like that. I like that. Now, before we wrap up, Dr. Kim, I know you have done an enormous amount of preparation for this. So, if there's anything that I have not specifically asked about regarding ketamine for anxiety in your patients or in your experience that you would like to bring up, I'd love to just give you the floor because I know you had prepared lots of anecdotes and all the things. So, please let me know if there's
I,
something
I
I have
think
missed.
I think that we've covered sort of the key features. The broad takeaways are to remember what ketamine is and is not. That we should approach maturing this field with eyes open and good intention, and trying to figure out what the optimal path forward. And I think that there's very likely more than one. While I am a huge advocate for ketamine assisted therapy, there are folks that advocate for ketamine therapy. I, you know, we could go on for 3 days talking about the relative merits and downsides of ketamine therapy versus ketamine assisted psychotherapy, but emphasizing that the critical importance of therapy in folks finding that better version of themselves. One of the things that I like to talk about when I engage with patients is we're creating an opportunity for you to rewrite your story. And that, I think, says a whole lot. And I'm just so grateful that before I check out of my career, because I'm getting on in years, that I get to do something meaningful that stands to meaningfully help a whole bunch of people. It's been a pleasure.
I love that. Thank you for that wrap up. And I will just say for everybody who tuned in because you may be struggling with anxiety, I've been there. I understand you and know that there are so few things that have probably been helpful. And the one thing that, has been handed out, generally something like a benzodiazepine has so many side effects and people have more difficulty, struggling with that on top of anxiety sometimes if that becomes a problem in and of itself. So that yes, we come to you today without just like a lot of other things. It's so new in the ketamine research field, but showing so much promise. So, Dr. Kim, I appreciate you bringing these tools to people who may be struggling and different ways to think about anxiety, ways to view ketamine, ways to view the research that has been done, that hopefully they can take these back and apply them in their own lives and hopefully to ease their own struggles. So, can you tell us where to find out more about you and Noma?
Certainly. For anyone interested in the work that we're doing, our website is nomatherapy.com. From there, you'll sort of get an overview of our program and ways to connect with us. And perhaps you'll find me on this podcast in some future day where we get to talk about some other very interesting question.
I'm taking that as a yes for any future invitation, Dr. Kim. This is going to happen. I thoroughly enjoyed having you on. Thank you so much for all your preparation and for coming and sharing your wisdom with us.
It's been a pleasure.
All right, for everybody else out there, until next time.